One of the main ways of learning that I believe works for us, especially for entrance exams, is when learning is visual, when there are some mnemonics at least to guide us by, when there is a mind map that we start creating, and when there is some association. So, with that in mind, let's get started with the very basic. What is MSc? MSc stands for Mental Status Examination. Now, what is it? It's a structured assessment which is done by the mental health professionals like psychiatrists, psychologists, counselors, and so on and so forth. How is it done? Simply by observing, that is your observation power, and think of it akin to how there is systemic examination for other fields. We have something called MSc, in which we observe, and not only observe but assess by asking questions, and in that way we try to assess their cognition, their behavior, their mood, their memory, the thought process at that cross section. This helps us diagnose, this helps us in finding a treatment plan, and also seeing how much better is somebody getting over a period of treatment with medication, with interventions like therapy, ECT, RTMS, and so on and so forth. So let's dig into the most important MCQ pertinent area about MSc, which is hallucinations. So, what are hallucinations? What are the various types of hallucinations? What are the causes of hallucinations? And what are the pathways involved? All of these four areas make up for a bunch of MCQs. If you see the most asked questions from psychiatry in the last few years, hallucination in some or the other way, especially areas around schizophrenia, types of hallucination, pathways of dopamine involved, they end up creating some or the other contribution to the psychiatry MCQs. So, hallucination in a nutshell is a disorder of perception, not of thought. Delusions are disorders of thought. This is the biggest difference. How we think is delusion, how we feel or perceive is hallucination. When that modality is affected, that is hallucination. Now, hallucinations are when there is a sensory experience or a perceptual experience without any external stimuli. So, if I had to give an example right off the bat, it means if I could hear things without it actually being heard by others, or I could see things that others could not see. Those are the basic ways. It means that seeing things that are not in an environment, and Carl Jaspers, who's a famous psychiatrist, said that it is false perception without an object. Sometimes they ask about Carl Jaspers as giving the definition for hallucination in the MCQ. One important area, very important, is what are hallucinations and what are illusions, because while both are disorders of perception, but they are different, same but different. Hallucinations are sensory experience without an external stimuli, but illusions are misinterpretation of an external stimuli. So for example, if I would see a curtain moving and I would think there is somebody behind it, the thinking part is delusion, but the curtain moving and me perceiving it in a way that there could be something behind it, somebody behind it, that is the illusion, because it is actually really moving, versus me thinking there is somebody in front of me while there is nobody but it's just air. That is hallucination in a nutshell. So remember, hallucinations are internal, whereas illusions are always externally generated. They arise from external stimuli. Another important MCQ caveat. Similarly, in hallucinations, it is a subjective experience which is very real. There's a lot of convincing that the brain has given. Whereas in illusion, if you go closer to the curtain and you move it around, you look behind it and say, wait, there's nobody behind it. So it is just a distortion, and you can correct the inspector by going close. You can kind of convince people that no, wait, this wasn't real, I just imagined it. In Hindi we call it bhram. It was just a figment of my imagination. That's akin to an illusion. Hallucinations can involve any senses, which is sight, sound, and we'll come on to what are the different types of hallucinations, of course. But illusions again can be distortion of any real stimuli, the keyword here being real. So hallucination examples are hearing voices, seeing things not present, whereas illusions are when we see a cloud and we say that, this cloud looks like a particular animal, which is called pareidolia, by the way, misjudging the size or misjudging the shape. Again, a common MCQ is pareidolia. What is pareidolia? Seeing shapes in clouds, a type of illusion. Let's take up some MCQs. Which of the following best distinguishes an illusion from a hallucination? A. Illusion involves misinterpretation of sensory stimuli, while a hallucination does not. Illusion is false perception that arises from and a real external stimuli, real also, external also, while a hallucination occurs without any external stimuli. Illusion is commonly experienced during dreaming, while hallucination is only in waking states. And D is illusion perception shared by multiple individuals, while hallucination is a private experience. Now think about it. While a lot of them will seem correct, the correct answer is what I emphasized on, real and external, and it's a false perception from an actual real external stimuli. So the answer is B here. Which of the following is a characteristic feature of hallucination? Are you aware of the unreal nature of the perception? Do you have insight in it? Perception is there without an external stimuli. Is there a delusional interpretation of the perception, or is there a shared perception by many, many individuals? As you know, we've been emphasizing what are hallucinations. The answer is very clear-cut: perception without an external stimulus. The other things are not relevant here at all. Now, the treatment of hallucinations is always through some or the other modality. Hallucinations have to be treated. They typically don't pass off on their own unless they're in the format of delirium or maybe, a substance, where of course they may pass off when the substance wears off. So there are antipsychotics, first generation, second generation, third generation. All of them act on dopamine. Some act on serotonin as well. Let's talk about the dopaminergic pathways of the brain. Very relevant, very important MCQs come out of it. There are four main pathways. First is the mesolimbic, second is the mesocortical, the third is the nigrostriatal, and the fourth is the tuberoinfundibular. I'll try to break down each one of them and try to highlight which part goes from where, what does it do, what does it contribute to, and what will happen if a problem comes in it. So the first is the mesolimbic. Now you can see the meso, that is, it's going from here to here. Now the limbic, so it goes from the VTA to the limbic system. So essentially it includes the three important parts in the way, which is the hippocampus, the amygdala, and the nucleus accumbens. Now this is the first part, the meso and the limbic. So remember that on the way VTA meets so many other nuclei as well. It is the basic internal reward system, the motivation system that we keep talking about. It plays a role in motivation, the emotional response, and reinforcement. So understand that when you are not motivated, when there's depression, when there is psychosis, when there is ADHD, when there is substance abuse, your mesolimbic pathway can be affected as well. Now, the second is the mesocortical. So again, the meso, and it goes to the front part of the brain, which is the prefrontal cortex, the PFC. The VTA goes from the connection to the VTA to the PFC, and this helps in the cognitive control, the attention, planning, decision making. It makes you who you are. How do you decide what color to wear? How do you decide what to eat? It helps again, ADHD, this part is also affected majorly. It helps you in making better judgment. Third part is very interestingly substantia nigra to the striatum, and it includes two of the pathways on the way. Now these are the two of the pathways that essentially come in the way, which is the CNP. I try to give that mnemonic to people, CNNP, that is caudate nucleus and the putamen, and this is the more movement part of the brain. Notice when it gets affected, it leads to Parkinson's disease. Similarly, when it gets affected, you actually can have drug-induced movement issues, that is called EPS, extrapyramidal symptoms. So that is another part. And the final part is the tuberoinfundibular pathway, which goes from the hypothalamus to the pituitary gland. And a problem here will lead to increase in prolactin, will lead to galactorrhea, will lead to a woman saying that her periods are not coming through, will lead to somebody saying that, my breasts are secreting milk without me being pregnant, or a male can also have that sometimes. So that is just your prolactin increasing. So those are the main areas, four major areas in the dopaminergic pathway, reward or pathway, or the different pathways of the brain involved, especially big part in hallucination because the treatment part affects here. Let's take up some questions. Rodriguez, a 22-year-old college student, visits a psychiatric clinic reporting distressing auditory hallucinations, describing that they are hearing multiple voices which criticize and command them, and these voices say to harm themselves, causing distress, interfering with daily activities, and there is no history of substance abuse, or there is no other medical history. What would be the most appropriate initial treatment for managing Ms. Rodriguez's distressing auditory auditory hallucinations. It's been mentioned what kind of hallucinations to describe more specifically, and the diagnosis most likely seems to be schizophrenia here. So would you go directly for CBT? Would you go directly for antipsychotics? Would you go directly first for ECT? Would you go for encouraging relaxing technique and stress management? Now between B and C, a lot of people will say, why not C? The answer is B, because the first line management should be medication. It could be injectable or oral. The choice of antipsychotic depends on factors like her age, factors whether conception is on the charts or not, somebody is in the family way or not, or planning a family very soon or not. Again, the functionality, sleep, and so many other factors. But directly ECT is given in certain other conditions and not directly in such a clear-cut case where medication will have a better outcome right off the bat. Which neurotransmitter is often implicated in the pathophysiology of hallucination? The answer is dopamine. Yes, serotonin too, but dopamine primarily. Now, the 5 types of hallucinations are in the 5 modality, because we said they are the disorder of perception. So this is how we perceive, right? Through our eyes, which is the visual hallucination, the olfactory, which is the nose, the auditory, which is the hearing, the skin, which is the tactile, and the taste, which is the gustatory. Let's talk about auditory hallucination. Most common hallucinations is a very common MCQ is auditory hallucination. And the content can be conversational. They could be talking to you, or they could be commanding you, saying, go get there, don't go sit there, go hurt yourself. They can even be criticizing, have you seen that person, when she walks she looks really funny, or she's created so many problems for herself. So they may be commanding, or they could be commenting voices. Sometimes they could be more than one person also. These voices could be there, they could be sounds, they could be other things that others are not perceiving. This chart is a very simple way of understanding the common causes of not only auditory hallucinations but also a lot of hallucinations. Psychiatric disorders are the most common causes, of course. Substance abuse is also a common cause, because hallucinogens typically cause a lot of hallucinations. People try to experience different modalities through these hallucinogens. Now, neurological conditions specifically like epilepsy, stroke, brain lesion, temporal lobe epilepsy can also lead to some hallucinations. But again, this is a common chart, although it says auditory here, but find a lot of answers from here about common causes of hallucination. Similarly, sleep deprivation, extreme fatigue can also lead to auditory hallucination. Sometimes in grief also. So stressful experience and trauma is written here. After PTSD or after the grief of loss of a loved one, also you can have an experience that they're calling out your name. Even migraine and seizures can be having a aura in which a person may say that they could hear things that others could not hear. Also sensory deprivation, if you lock somebody in a dark room without any stimulation, any sensory stimulation, or if you lead to overstimulation, photic stimulation, or you lead to somebody with very loud noises, they may end up hearing things even in the aftermath of a concert. Again, these are subjective experiences which pass off very fast and hence do not necessarily require treatment, but auditory hallucinations are common in these cases. Which sensory modality is most commonly affected in individuals experiencing hallucinations? As we said, the answer is auditory or hearing. Which psychiatric condition is most commonly associated with auditory hallucinations? Of course, I did say PTSD, it can happen, but the most common is schizophrenia. Hallucinations seen in schizophrenia are people having insight in them. They know that it is not a hallucination, or are they induced by external stimuli? Are they commanding in nature, or are they in sync with reality? While yes, all hallucinations are external, they're not induced by external, but they are external. But notice we just discussed that the commenting and commanding voices are very common. So this is a common auditory hallucination seen in schizophrenia. Let's talk about the other one, that is visual hallucination. Seeing things that are not there. It could be not only simple shapes, but it could be very complex scenes as well. There is something called Charles Bonnet syndrome, in which blind people can have hallucination, who do not have eyesight can also have hallucination, visual hallucination for that matter. They can even say that they're seeing people standing in front of them. There are neurological conditions, there's dementia, TLEs, temporal lobe epilepsy. There are drugs which can induce visual hallucination, like I said, the hallucinogens, certain psychotropics, delirium, stroke, all of these can lead to visual hallucination. Now, one interesting thing is something called tactile hallucination, in which a person may feel that bugs are crawling under their skin or over their skin. Some even see it, but a lot of them also feel it. They say that there is tingling happening. Very common in withdrawal. All kinds of drug withdrawal, we see it super common. Even DT is delirium tremens, in which a person may say that there is something, that there are ants or there are bugs, or bugs are particularly seen in substances, for example, opioid withdrawal. And we call this formication, common MCQ. What is the sensation of the ants and bugs crawling under the skin without reason, which is a tactile hallucination called formication. Next, let's talk about the olfactory hallucination. Now, these are parosmias, in which you may feel that something which smells a certain way has been completely changed. So, a flower is smelling of onion, or an onion is smelling of roses. Now, familiar sense, this usually happens for familiar sense. This is common, this is very rare actually, not common at all. And we also find certain people saying that they can smell burning things, which is phatosmia. And another common olfactory hallucination people have is, which may be a hallucination or maybe just a delusion and has to be double checked, is something that they smell on their own, the odor, that their odor is troubling them, that others are getting troubled by their odor as well. The final one is the gustatory hallucination, which is in which you think that the taste has changed completely, usually always combined with delusion and some other hallucinations, not seen by itself very, very often. Let's do some questions. Hallucinations due to drug intoxication are often associated with which type of substance? Let's take up some questions. Hallucination due to drug intoxication are often associated with which type of substance? Which substance can cause it? Can antidepressant cause it? Can benzodiazepine cause it? Antipsychotics cause it? Hallucinogens cause it? Clearly, the first two are medication, and the fourth one is also medication for this. So, hallucinogens are the drugs, which are contraband drugs, can cause hallucinations. The answer is C. Which age group is more likely to experience hallucinations related to medical conditions? Now, notice in all of the options, while yes, it can happen to any age group, interesting thing is that some of the most common causes that I showed you in that chart were all age related, meaning things like stroke, things like dementia happen at a certain age. So the answer is elderly by default. Next, let's talk about another interesting area.